And one more thing, in 2021, 22 and 23, the most prominent two texts in orthopedics, the Campbell, they have described it, and the Bible of pediatric orthopedics is Sturgeon's. They have all described this procedure as only one. Actually not new, sir. Yes, sir. 1950s.
It is Charlie's procedure, it is methodology rodding with bone, on
Yes,
bone
sir.
grafting.
There are some modifications.
Thank you, Professor Rizvi sir and Professor Salam. Our next presenter was Dr. J.M. Jahangir. His paper was Atopic Paranebral Cyst Decompression. Any questions to J.M. Jahangir? Thank you. Our next presenter was Dr. Wakil Ahmed. Any question? No question. Thank you. Please, there is a stand behind you.
Thank you, sir, for your very brilliant presentation, which from where I could learn a lot of things. But I have a question to Professor Wakil, sir. You showed in your slides drawing two lines, one probably the maculum's line and another one the second line perpendicular to that line through the acetabulum to show both the safe placement of cup and the safe placement of screw. My question is, what is the actual safe position of acetabular cup placement?
Actually, the angle, the two lines here, the safe zone, that is the safe zone posterior, that is the safe zone for the screw placement. But the safe position of the cup is the combination of the inclination and inversion. That is usually in the lateral position of what we do, we usually try to maintain the inclination angle around 45 and inversion around 15. It may range from 10 to 25 and inclination angle may range from 35 to 45 like this, but we want to maintain the combination of these two inclination angle and inversion, and that is the safe zone of the cup in a healthy man. But there are some difference when there is some spinal obliquity, there is spinal deformity, there is a different issue, and we have to adjust the cup position in that case. Sometimes we need to do the more vertical, sometimes we need to do the more horizontal, according to the deformity and spinal obliquity. Thank you very much.
Thank you, Dr. Wakil. Any questions to Dr. Shoaib Akhtar?
Sir, assalamu alaikum. Sir, me Professor Jahangir sir ke question korte chai sir.
Bolo.
Sir, I am Dr. Ghulam Mahmood Shoash, Assistant Professor Orthopedic Surgery, NITOR. My question to Professor J.M. Jahangir Hussain, sir.
Yes?
J.M. Jahangir Hussain, sir. Sir, you discuss excellent presentation for your suprascapular nerve impingement. My question is, suprascapular nerve supply the supraspinatus and infraspinatus muscle. So there are a lot of DDs regarding this condition, as like rotator cuff tendinopathy, cervical spine injury, or C5 or C6 related injury. So what is the key findings, clinical findings, when I suspect the only suprascapular nerve impingement? Because you mentioned confirmed diagnosis by EMG or MRI. So what is the key clinical findings for suspect the suprascapular nerve impingement?
Thank you, Dr. Suhas. It's a good question, and it is valid and authentic. You know that as a cervical spine surgeon or a shoulder surgeon, you must know the clinical how you differentiate the lesion from the cervical spine or the lesion from the shoulder, as because most of the coincidence. So it is why I personally I know the history of the patient and physical examination. And because you must differentiate which side origin of this type of pain. When we suspect this is a most of the cervical spine pain, I always find there is any burning incision over the shoulder or over the scapula. as because most of the shoulder cervical spine pain is associated with skin. But in case of most of the shoulder related pain, deep seated pain, it is mostly with the muscular. This is my clinical understanding. So this clinical understanding then give you a diagnosis as before there is non-entrapment, either may be suprascapular loss or it may be spinal gland loss. So the when suprascapular, it involves two muscles, supraspinatus or infraspinatus, both. And when it is involved at the spinal gland nose, it should be only infraspinatus muscle. Sometimes when both muscles are involved, but supraspinatus cannot be seen, just over that muscle. These are the clinical. Then in physical examination, usually you can determine either supra involvement, then MRI and CT. I think it is the good, and but my final diagnosis is at the operative phase, para-operative, arthroscopy.
Thank you, Dr. Jahangir. Thank you, Dr. Suhas. Dr. Shohid Islam Akram presented many of his spine surgery in Bangladesh. I think it is nicely presented. May not be any question.
Professor Moin, I have a question to you.
Okay,
May I
thank you,
ask?
sir.
Spine surgery is now an emerging surgery in Bangladesh. In many centers,
Yes.
you develop this with enthusiasm. And I know that personally, some of my colleagues, Professor Shalom has developed one hospital of his own, one of the spine doctor hospital where the APAC center is recognized. So can you please develop a center of excellence in Bangladesh, combining all the all the faculties, one excellence center of spine?
Yes, sir.
So you know the CRP is not progressing much more in this aspect. Once upon a time they were working in this aspect. So is there any scope of giving any post-graduation degrees or diplomas only on spine? Please
Yes, sir. Thank you, sir. I think we have a dream to start a center of excellence like a spine injury center in India and many more countries. In our CRP is basically rehabilitation based or physiotherapy based. But we need a spine center like all standard sophisticated surgery as well as the rehabilitation and other occupational therapies and physiotherapists, everything in a center. I think in spine we can establish in government sector also like a big center in spine injury center in India and other standard center in all over the world. Thank you, sir. Sir, possible.
So this should be our next vision to establish the spine hospital with collaboration private government sector. I think. Our next presenter was Dr. Mohammad Siraj Salihi. Any question?
Sir, Assalamualaikum.
After this last question, we have a photo session for 1 minute.
Me, Professor Monjur, retired from government job 10 years back. Shizu is one of my favorite students. Thank you. He's doing a very heroic, he's dealing with heroic situation in orthopedic surgery. My question is, in your conclusion, you have advised not to do any FNAC or trocar biopsy. Why? And another question is, the operating surgeon who will do the biopsy, what is the reason behind this? Thank you.
Thank you very much, sir, for a nice question. In our country, most of the operating surgeons are very much familiar with FNAC, but we did not reach the diagnosis of the bone tumor cases. So we must do the core needle biopsy, and it is ideal and less contamination, so we can do the limb surgery. And your second question is, why core biopsy must be done by the operating surgeon? Because he knows the tract, and in final incision he will excise along with the tract, along with the tumor. So biopsy must be done by an operating surgeon who knows the limb surgery. Thank you very much, sir.
Thank you very much. Thank you, please.